Hello, friends. Thank you for tuning in again. I have once again been lucky enough to have a chat with Dr. Lotta Borg Skoglund. She is, as you probably already know, but I have to introduce her because how many accolades does this woman have? Co-founder and medical director of Letter Life. She has over 25 years of clinical experience with ADHD. She's a senior consultant physician as well as associate professor in psychiatry at the Department of Women and Children's Health at Uppsala University, the Department of Neuroscience at Karolinska Institute. She is the author of 6 books with another on the way, which we will talk about in this episode. I cannot wait to read it, as it's planned to be released first in English. So that'll be a first for her. She's co-writing it with her self-proclaimed work wife, Dr. Helena Kopp-Gallner, and it will be full of practical tips that you can use as a neurodivergent woman to help get through life with a bit more ease. And a quick note before we dive in, if you enjoy this podcast, please share it. Please subscribe. If you don't already, hit that little plus button. And if you can, I would really appreciate if you write a review. Those help this podcast grow, which means it helps me continue to get amazing guests so that we can all continue to learn on this journey together. Now, as has become pretty standard for me, we just jumped straight into the conversation. So let's get into it. Enjoy. Thanks so much again for carving out time. I know you're busy.
Great to talk to you and to see you and to also everything that you're doing, like all these amazing, like awesome stuff that you're doing. So great to see. I'm just, yeah,
trying.
blown away. Yeah.
I always struggle when I talk about Letter Life, not because it's not genuine, but I worry that people are like, oh, is she just getting paid? And that's why I'm always like, it's not an ad. It's just genuinely a really good resource that everyone should be accessing. I'm just like, let's talk about it as much as we can and get it out there as much as we can. And that's what
I'm really grateful for that. That's awesome. So it means a lot, really means a lot. I think that is like the most powerful stuff, where going into the community and reading all these like amazing stories, and also all these like really generous advice that people are giving to each other, and women are like paying forward. So I think we need something like that.
That's what I was just thinking. It's hard because it's not just because you're Sweden based, but it's such a multi-pronged approach, because you are doing the research and you're working with researchers, but then also you want the lived experience, and you want more, for lack of a better term, like lay people who are speaking about it and spreading that word of mouth, but then also contributing, like you said, like the community board. I think that's one aspect that probably could be talked about more for Letter Life, is the community board aspect of it, because there's such good, like you said, sharing and people being really open and really just vulnerable and
it
giving.
feels like it's such a safe and generous environment that it's also so helpful for so many people. And I get contacted by women every day who's been like so uplifted and felt so seen, and also finally got the energy to do something because the advice is coming from someone who's actually walked in their shoes. So it's so much easier to take that advice than from a healthcare professional that can often feel very like anonymous, or like, so they don't really understand or see how I struggle, and then the advice also becomes like tainted by that. So I think it's a lot of things that we need to factor in here to understand why you don't act on the advice that you may get from healthcare.
And sometimes it is that just that little bit difference, because in the app there is still technically healthcare advice. There's advice from you and other clinicians, but it's tailored to be specific for someone who has struggles with executive functioning, which is what so often when you go to your doctor, they don't know that piece. Like they're just literally not
No, true,
educated enough
true.
to understand
Yeah.
how to break something down enough. And
No.
I've talked so much recently about the mental load of motherhood, among other things, but how even something like making dinner, it's not just one
Yeah.
task. It
No.
is 40
It's
different
like a
tasks.
thousand different steps that can go wrong. So I struggle with that all the time. It's like so many things that could go wrong. And that's also one of my, I think, main reasons for procrastinating. It's because I see all these different steps before, and I see where it can just go south, and then it's like, oh, it's no use in trying.
And that's
So
the struggle I think with, I think especially so many late diagnosed women is, as a coping mechanism, we have learned to be perfectionists to try and catch ourselves before
mhm.
someone else catches us.
Yeah.
And so often we do get caught in that overwhelm of like, well, if I can't do it perfectly, if I can't do
Mhm.
it just
Yeah.
right, I just won't do
Mhm.
it at all.
Yeah. Yeah. That's so great that you're saying that, because me and Helena, we are writing this book, and we've been doing this for like 3-4 years now. But now finally we have this deadline, and it's in September, so we will send it away there. And this is actually what we are writing about right now, in the final like chapters, trying to give like really practical advice without, because we can't do it as healthcare professionals as we can do when we sit with a patient in front of us giving this tailored advice to that person. But it's still, there's so many things that is generic for us as women with ADHD, as mothers with ADHD or and autism. And this the more like pleasurable parts of writing this book is actually to collecting everything that we have gotten back from Letter Life as well, and also from our patients, the feedback basically, and try to do it in a way that will feel meaningful and productive. So it's going to be so great to hear
And it
what
will
people
come
think.
out in Swedish and English at the same
No,
time.
no, no, only English actually. So this is such a, yes, but this is such a crazy project. We embarked on this crazy journey, but it's obviously it will need a bit more editing, I think, because this is not our mother tongue, obviously.
You say
But,
that,
but
but
yeah.
like I don't think there's any, maybe you feel a struggle, but as the other end of the conversation, it does not feel like you
Oh,
have
that's
any
good to
struggle with
hear,
the
because
words
that
at
is, yeah,
all.
that's great to hear, because that is actually one of the things in my perimenopausal brain that has taken the worst hit. That is finding words and remembering names. And then especially then I can have like days now that I've never had before, but days now where I just like wake up and cannot speak English. It's like I cannot find the word. And I never know beforehand if I'm going to end up in a podcast like this, like just sitting like a fish. It's like, what am I trying to say, and how come, these things that works so well, I can stand on a huge stage having a keynote speak without even preparing, and then some days, and I don't know why, my perimenopausal hormonal brain just would not speak English. So and it can go so fast and up and down, and I associate it extremely with the perimenopause actually.
It is.
Mhm.
And it's funny, I was just having this conversation with a friend. So I'm 37, she's 45. We went to see a show on the weekend, like kind of like a comedy show, and a big part of it was perimenopause. And I
Mhm.
said to her, I said, that is because I've just started in
Mhm.
that little journey. And that's one of the main things I'm
Yeah.
noticing, on top of like my emotions not being okay. But
Yeah.
I forget words.
Yeah.
And just like you said, and the
Yeah.
weird thing for me is I can feel it in my mouth. Like I can literally feel
Exactly.
the word in my
Yes.
mouth.
Yeah.
And
Mhm.
oftentimes I can visualize the
Yeah.
letter it starts with, but
Yeah.
like the
Yeah.
rest of it just doesn't come.
No. Exactly. And that is scary. No wonder so many neurodivergent women will seek out their healthcare professionals asking if they think they are developing dementia. No
Yeah.
wonder, when this is like, it is like my brain is this sponge with a lot of holes in it. It's like there's things that is not working at all, and then suddenly these things are working. And it's like, so it's very, very ADHD when you think about it. Like, okay, works one day, not the other, la, la, la. So more that than dementia, really. But both annoying and also almost fascinating, I would say, because it is obviously for me that it is also tied to hormones.
I have been debating doing like experiments on myself. That sounds terrible. More
Mm-hmm,
like because I already track, obviously,
mm-hmm,
big help
mm-hmm,
and thanks to Letter Life. But I track and say with my emotions, it
mm-hmm,
has gone from pre perimenopausal, like when I was just normal. I would have 1 or 2 days where I
mm-hmm.
was incredibly aggro and irritated and I just hated everything. Now it's becoming 10 days
Yeah.
and it's erratic. It's not every
Mm-hmm,
single day, but some days I'm just incredibly overstimulated by nothing. Some days
mm-hmm.
I'm aggro, but it's not every month. And
No.
that's been I'm like, is it the months that I don't ovulate? Is it the months that I ovulate? I'm just debating starting to run these little tests on
Have you
myself.
listened to the talk by Helena at Letter Life, the one that is recorded about the perimenopause and menopause? She has a longer
No, I haven't
lecture.
seen that yet.
No, but you definitely need to see that, because one of the take homes there was, because this is actually my experience as well from my late 30s, basically, that when it was just about PMS, then I could so clearly tie it into these days. And okay, there are more days and there are like, but still there was some kind of pattern that I can understand. But then when it comes to perimenopause, estrogen levels are declining in a swinging manner. So it's not like
Mm,
it's constantly going up, because then you could also relate to that. And I think as ADHD or as neurodivergent women, we are very tough in that sense. If we just understand, we're happy to join that battle also as well, right? So we do that as well. So it's fine, just bring it on. But if we don't understand what's happening, then things become really, really difficult. So I would say understanding that, because I thought that, okay, but everything is just declining, so I should feel a little worse every day, that's fine. But no. So when it's look up, it's like, wow, I'm super. And then so this is what's happening. And I think for me then, and obviously you need to talk to a gynecologist and to discuss if like menopausal therapy is feasible for you. But to a great extent, I feel like a lost generation where we were advised not to even
yeah.
consider that, because our mothers did. And then these women healthcare initiative study came, and we realized that hormonal therapy could be associated to, for example, breast cancer. So that has been the truth for a long time, and as long as I've actually, when I studied medicine. And I think maybe that's also one of the reasons for why I know so little, and my colleagues know so little about this. And I'm also like, really, I've studied this. I am a woman myself. I have all the factors that needs to be there is there, and still I feel like I know nothing about this. And then I would say, like, the woman who is not educated in medicine, what do they know about this? They must enter
Thing.
menopause. I entered like completely blindfolded, completely. There was such a surprise when Helena said, could it be like perimenopausal? It's like, no way. But let's look at your ovaries. And then we look like, well, there's not many follicles left there. So probably it is not dementia, because I could fantasize up every single reason for why my brain was failing me. Yeah.
So I have age working against me because
Yeah. You were so
even
young.
though my doctor is very informed about hormones,
Mm-hmm.
she doesn't really want to put me on hormones just yet. Like if I really insist on it,
Mm-hmm.
she will. But her
Oh,
first was to want to put me on oral combined birth control. And I
yeah.
said,
Yeah.
100% not doing that, bad history.
Okay.
And
Okay.
also quoted the
Mm-hmm.
study that
Mm-hmm. Yeah.
ADHD girls are more likely
Yeah.
to have depression, only to back up my own personal experience. And then she
Yeah.
said, try progesterone only. And
Okay.
my issue, I've never tried progesterone only, but I know
Mm-hmm.
of similar to the oral combined, so many neurodivergent women are extra sensitive to the progestin versus a
Mm-hmm.
bioidentical progesterone.
Mm-hmm. Mm-hmm. Because what I would say is for one group of women that we meet, the combined pills, especially for PMS and especially for early perimenopausal symptoms, can actually work. What we think is that it is for those also ADHD women that you forget to take them and your hormones fluctuate even worse. So
Mm.
if you yeah, so that is also perhaps one of the reasons why this didn't work when we were younger, and that it might work now when our lives are more predictable and you can put that together with your baba that you take every day. But when we were a teenager, maybe our lives wasn't like arranged. So there are a lot of potential or different explanations that needs to be factored in and needs to be also part of this kind of not very explored field of research around this. But I would say your lived experience, you need to take that very high into the level of evidence in that sense. I think that's one of the most important parts to factor in.
And I think some doctors, just in general, for someone my age and even into the early 40s kind of age of perimenopause, it is suggested that they suggest some type of contraceptive. But in my case, in my situation, my partner's had a vasectomy. Like we don't
So you don't
need
need,
for that.
it
So
that.
that's why I'm like, can we just skip to
Yeah.
the very
Yeah.
tailorable,
Exactly.
fine-tunable?
Yeah. Yeah. You can take that out of the equation anyway.
Yeah.
So that's a good thing. Yes, that's a good thing.
Because that's what I have to try and remind other women when we're talking about perimenopause, that I think there might be this myth that you can't get pregnant. I'm like, oh no, you can very much still get pregnant.
Mm-hmm.
Your
Mm-hmm.
chances are lower, but you
Yeah.
can still
Yeah.
get pregnant.
Yeah.
And
Yeah.
your
Yeah.
cycle
Nothing
is
is
so
100%.
erratic that
Mm-hmm.
tracking is not really
Yeah.
on
Yeah.
your side.
Exactly. No, 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 no. No. So I think that's a very common case actually, that you feel safe about that, but nothing is 100%. Not even like the most, like there are grades of how well protected you are, obviously, but there is also a contraceptive is only as good as
As its
how it's intended
user.
to be used.
Yeah.
Exactly.
I'm curious, like with hormones and perimenopause and all of it,
Mhm.
we know obviously when we look at like cyclical dosing, we know that without any intervention, our natural cycle is estrogen peaks, it drops, progesterone comes up a bit, and then
Mhm.
everything restarts. When we look at perimenopause, like we said, it's like this erratic decline. It's not just
Mhm.
a smooth,
Mhm.
smooth
No.
landing.
Mhm.
When HRT or MHT comes in place, and that helps to stabilize and raise
Mhm.
levels, but
Mhm.
you're still having this erratic
Mhm.
decline.
Yeah.
So how is, say, like stimulant medication? It's obviously still affected by the baseline estrogen levels,
Yeah.
but
Yeah.
is there any way to make that less hellish for ADHD women going through perimenopause?
That's a really good question, and this becomes so super tricky, and I see it in my patients all the time, because when we finally can disentangle what is going on in the PMS or in the like the more traditional or the menstrual cycle, so then we have to add this extra like dimension of not being able to rely on the cyclicity of the period, and that is so difficult. And when you add MHT or HRT, what you do is basically that you increase the baseline level of estrogen. So what it's intended to do, it's like it's going to prevent you to drop below that level where you get the physical symptoms, and also where you get the increased risk for dementia or the increased risk for a different cognitive impairment. But that is just the baseline. So what we do there is that we increase that baseline, and then we can rely on that our ADHD medication have that baseline to drop down on. But then you have the exact same thing as will happen in some women during the menstrual cycle, namely that during ovulation, when estrogen levels get high, you can experience this kind of increased energy, and not always in a good way. So you can experience is that you get scattered, you get stressed out, you get irritable, you get more impulsive maybe, and this is so very difficult. And the only kind of advice that what we have right now is to keep tracking and trying to understand. And for some women, it's actually easier to break it down a little bit. And so I always advocate that long-acting stimulants should be kind of the base, because what we don't want is add to this going up and down. But it also becomes more difficult to tailor then if you feel like, okay, so a couple of hours into this day, it's like, oh my God, it's one of these days, and I took my kind of higher dose of this long-acting stimulant, so this is going to be hell day. So then one way of thinking about it or discussing with your healthcare professional will be like reducing the dose for the long-acting, and then add like short-acting that you can take days where you think, okay, so this was actually really too low for me today. But we're not there yet where we can actually predict into the future this erratic pattern of perimenopausal estrogen fluctuation. So that is really, really difficult.
And then we have, like, I play this fun game with myself and a perimenopausal symptom going, I'm starting to feel heart palpitations. And I'm like, is it just my baseline hormones? Did I take too much medication? Or is it perimenopause?
Yeah. But you know what? Your guess is as good as ours. And when I say ours, I mean the researchers and the clinicians here, because we're not there yet. So I think you're very wise to line up as many hypotheses as you can, because again, then this is something that we can live with. What we can't live with is having no explanation for why hell breaks loose and it's like clusterfuck day today or clusterfuck week. So what I think anyway, that so many of my patients with ADHD, they're super tough when it comes to this, but they need some hypothesis. Okay, say you have 10 hypotheses then. Is it perimenopause? Is it the medication? Is it bad sleep due to my kid running a fever? Is it stress at work? This is also why we have tried to design this 24/7 ADHD 24/7 model to also have the questions tailored to that. Maybe we can live with not having the exact scientific based answer every time, but just bringing up all these hypotheses on the table is, for me anyway, it's a little bit soothing, because I'm not crazy anyway, because that has always been my biggest fear, and also sometimes being actually emphasized, or as you say, like even enforced by friends and partners and colleagues and healthcare professionals, like, what are you doing? And but for me, just to be basically like validated. And he doesn't have to give me a formal answer. He doesn't have to say like, this is how it is. He just has to say that, okay, yeah, it's a valid hypothesis. Let's see what happens in 2 days.
But that's how we find anything out, is you start with a hypothesis, right? Like that's the base of research and scientific evidence. And
but to be validated in that, I think that is something that I've missed in the healthcare system, because when I come with this hypothesis, it feels like healthcare professionals are rather bothered or feel inadequate if they can't answer my questions. It's like, oh, it's in your head, or you're just making this up, or because and I can definitely, if I take on my other hat as a healthcare professional, as a doctor, and I have a patient having 1,000 questions where I realize that I don't have the answers, I can feel kind of inadequate there. And I can also feel like, wow, I think it's good that it's 4 weeks until she comes next time, because I don't want to feel like this, because all these questions and I have no answers. So that is tough on you, because as a doctor, you want to do good. You want to help your patients. And there are all these questions that I don't have any answers to. So I think that's also something that we have to be very like self-aware of as professionals. It's like, you know what? this crowd, they have heard this. There's not enough research. They have heard it so many times. You can't just leave them there. We have to do something, and we have to build this hypothesis together. And obviously, we shouldn't experiment if we are uncertain about what we're doing, and if we think that if we can't like make sure that what we do is safe. But who am I if I say I can only do what is evidence-based, and then say, and then there is no evidence? Wait, either you have to wait until you become a boy, or you have to wait. In Sweden anyway, it's a lag of I think a mean lag of 17 years before a research finding actually is implemented in the clinical practice. So
It's
either you have to
similar. I
wait.
know it's similar in the
Yeah.
US and elsewhere.
So when you're working in a field like Helena and me, you will either have to tell your patients to wait until basically these questions are not relevant anymore because they're not in perimenopause anymore, or they're not ovulating, or they're less. So I think maybe you have to be a little bit brave and radical and a rebel in a sense if you want to do something anyway, because otherwise women will try to seek these answers in even less informed sources. So there will be all these places where you can buy this or that, and you can take this or that hormone or vitamin or blah, 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 that is absolutely not informed by any. And also, even more dangerously, they don't even admit that. So they say this is, science say, or research tell, or something like that, and then they roll out a lot of pseudoscience.
Or they cherry pick their information. I see
Exactly.
that in so many,
Mm-hmm.
I don't even want to call them like supplements,
Mm-hmm.
just mineral and
Mm-hmm.
adaptogenic combinations that are coming out now, powders and drinks and
Mm-hmm.
etc.
Mm-hmm.
And they'll cherry pick one piece
Yeah.
of actual research about one thing in their product that might
Mm-hmm.
be 0.2%, and they
Yeah.
will say it has ingredients that help with blah blah
Yeah.
blah, but like the amount of that ingredient in there is not even enough to make any type of difference.
Exactly. Yeah. So that is a charlatan trying to like rip you of money. But even worse is those that you see like, oh, so there is this amount of vitamin A, for example. And vitamin A is super important. And if this amount is good, then double the amount should be twice as good. And that is where the ADHD brain can just spiral down that rabbit hole. And if you're not transparent with what the other end of that message is, namely that vitamin A, for example, is teratogenic, it can cause birth defects in your child, or even worse. But often, as you say, if you cherry pick your research, then you just frame it in the way it's not untrue, but it's not the whole picture. And that can, in a world that is so complex as the medical world, that is actually dangerous.
And I think that's why we're so lucky that there are practitioners and clinicians like yourself, that you're involved in both sides of it. You're involved in the actual research, but then you're still working with patients, and you can take
Mm-hmm.
what you learned in your research last week
Yeah.
and have that inform your approach with
Yeah.
patients. And if more and more doctors and clinicians and professionals, obviously they don't have to be researchers themselves, but if they just stay up to date on the
Mm.
research, it will help. But I think
Yeah.
that's also why going to someone who, like, even if they just say they have a special interest in blah,
Mm.
blah, blah,
Mm.
it's going to help. So for, say, us as women with ADHD, like, my psychiatrist is someone who has worked specifically with
Mm.
ADHD for the last 30 plus years.
Mm-hmm.
I know he's going to be slightly more informed than just
Mm-hmm.
I don't know if I want to say generic, but like a non special interest in ADHD
Mm-hmm.
psychiatrist.
Mm-hmm.
And it's hard.
Definitely. Yeah. Yeah, but you have to have the heart needs to be in there as well. You have to have the interest, and you have to have some kind of passion for what you're doing. And I think that goes for not only for ADHD professionals, but for everything that you do in your life. So it's better if you have some kind of like a passion that is more than just because I can collect my salary on
Mm.
uh, the 28th of this month. So not saying that is what people mostly do, but I think sometimes when we are kind of not feeling validated, it can either be that there is no interest, no passion for these kind of questions, or as we said before, because we trigger feelings of inadequacy with questions. That is, so I would say one of the most important things for me that I have brought back from research would be how humble you have to be, and how humble you have to be for what people are telling you. What Helena and I are trying to do now in our new research platform, where we're trying to build a research platform for all us tinfoil hat syndromes.
Is this through
Yeah.
Goddess?
Yeah.
I wanted to talk about it
Ah,
before because I think
yeah.
it's adjunct to what Letter Life
Yeah.
does, but separate, and it's
Yeah.
so interesting. So can you go in detail a bit
Yeah, but
more?
definitely, yes, because our research group, we have me and Helena and Lisa Torell, who's also a professor of psychology at Karolinska Institutet in Stockholm. We have founded this research group. We call it ourselves the Goddess ADHDs, and it stands for Gender-Informed Research to Overcome Diagnostic Delay and Emotional Dysregulation through self-awareness and self-efficacy in female ADHD. So it's a huge acronym, but it's also a huge project. And what we have decided to actually focus on is what we are talking about, the clinical, the everyday life of being a girl or a woman with ADHD. What is significant for their testimonies and their lives and their stories and their storylines. And what we can see when we do these qualitative studies is, and also what we see from our previous epidemiological studies, is that first and foremost, you feel abandoned by healthcare. And that is such a paradox, since we, women with ADHD, at least Swedish women with ADHD, we consume 10 times the healthcare resources compared to women without diagnosis. So we are pretty expensive. And we are pretty expensive since we're not getting the right help. I think what we are doing and what we are hearing when we do these interviews is like, but they don't listen, so I have to go somewhere else. And they said that I'm just imagining this gut, this problem, this IBS problems, but I'm really worried that it is something, that it is might be something, because it is really impairing for me. And then I have to go to someone else, and then I have to go to someone else, and then so I think what we're seeing is a kind of perfect storm of not realizing, not validating what these women are actually experiencing, and then having them thrown into this kind of flipper game of healthcare utilization and consumption due to a lot of comorbidity, obviously, but also to what we think, what we call, with very much love. And I'm really people are so welcome to contact me if they feel offended by this kind of syndrome that I've tried to invent. But we call it the tinfoil hat syndrome. I'm not sure if that is the same thing in English, but in Swedish, that is basically what doctors are saying behind these patients' back. It's in their head, and reclaiming what people are actually calling them. We said, why not? We call it the tinfoil syndrome, okay? Because this is actually so a large part of what the healthcare utilization is all about. It's about things that never really are diagnosed with as a code of diagnosis that is actually okay, broken limb or whatever, but this is just like symptoms of
Mm-hmm.
fatigue, symptoms of some diffuse pain, and then there are these diagnostic entities that are also partly part of this symptomatic diagnosis. We don't know the etiology behind it.
Kind of like
Fibromyalgia.
fibromyalgia. Yeah.
Exactly.
Yeah.
Fibromyalgia, IBS, like diffuse pain symptoms post-COVID, in a sense, where we have the etiology, but we still don't know why certain people are so much like are struggling so much more. So all this where we again cannot back this up by science, but people are continuing to tell us that they are suffering. And so trying to reclaim that and trying to understand that, because we see that neurodivergent women are overrepresented in all these kind of diagnostic entities. And then we have a Swedish diagnostic entity that is specifically only diagnosed and have a diagnostic code or ICD code in Sweden. That's burnout. So that is exhaustion syndrome. That is carved out in the Swedish ICD from the Swedish National Board of Health and Welfare, and designed a diagnosis for that, like an adjunct diagnosis. So we have like a ongoing experiment in Sweden with this exhaustion burnout diagnosis that is not recognized, that is probably being labeled or diagnosed as something
Chronic fatigue
like,
or
yes, or adverse reaction to stress, or like prolonged fatigue or something like that. That is what we will want to explore and look at in our future in this goddess ADHD research paradigm, basically.
interesting. I love
Yeah.
how, and I know it's a small-ish, not landmass necessarily, but small-ish population-wise country, Sweden.
Mhm. Mhm.
But there is such a culture of research and
Mhm.
of using the population to get information and to actually put
Yeah.
funding towards that we don't see like basically anywhere else. And
No,
even other countries
Scandinavian
that's
countries are quite unique in that. So
outside
it's
of the
Denmark,
Nordic
Sweden.
world.
Yeah, exactly. Sweden, Denmark, Finland, Iceland, and Norway. We're pretty good at that, at collecting data on a more structured national level.
But I think
Dry.
even other countries that have social health care, because that obviously is a factor, right? Like I
Yeah.
speak to other
Mhm.
Americans who are still in America and they're like, I can't even go see a doctor because it costs so much
Yeah.
money. But even like I'm in Australia, we have social health care. It's not done.
Yeah.
And I really think so many other countries, this is like one of many things that we could look to the Nordic countries and
Yeah.
learn
Yeah.
from.
Yeah, hopefully. Yeah. So there are pros and cons with that. I'd say that as a clinician, I would say perhaps that a little bit too much of my working day goes to hunting this diagnostic code of this and that, because there's a cost to entering all this data into all these registries so that we get the best possible data. But obviously, as an epidemiologist, I'm again then super happy that me as a clinician did that, because then I can do all this great research.
So with Goddess, you're looking specifically at that burnout code that's been
Yes. Yeah.
created.
Yeah. So we are trying to do
What's
trans-professional research. So it's gynecologists, psychologists, midwives, they're nurses, they're social workers. So we want like to have a representation, and there's also obviously patient representation. So we have forums and panels with patients that is involved in every step of designing the research. So that is one part. And then we also have this multi-method approach. So we're doing epidemiological research, we're doing qualitative interviews, and then we're also now applying to the Ethical Board of Sweden to do research on letter life data.
Oh,
So
cool.
as a letter life user, you can choose and you can opt in to also contribute with data to research. And that will be then research exploring cyclical dosing, for example. If you are doing that together with a healthcare professional, what is your experience with that? And also all this tinfoil diagnosis where, okay, so what's your experience with that? And what was helpful? And how do ADHD medication, for example, affect these somatic symptoms. So we're really interested in the real life experiences and the real life outcomes of women with ADHD and the different aspects of the ADHD life. And obviously also then with the autistic traits and those who have comorbidity with autism, because that is also extremely interesting and difficult to get good data on, since in the DSM-4 we were not allowed to actually diagnose
Do
both
both.
conditions in the same individual up until 2013. So and we realized more and more how like intertwined these and two diagnoses are, and especially probably in girls and women.
And I think too, I don't know how you would do this because there would be no data, but looking at someone like myself, so I'm officially, clinically, whatever you want to call it, diagnosed ADHD, but I'm only self-diagnosed autistic, in part for a lot of things, my citizenship status being one of them, me being very low support needs, and I've very much manufactured my life in a way that I don't need accommodations. I work for myself, etc. So I won't most likely seek a clinical diagnosis, but I still exist. I still am. And that's where I think like your interviews and your speaking to patients is so important, because you're not just looking at the data points.
No.
You're looking at the individuals as well.
Yeah. Yeah, the individuals and the trajectory across life, I would say also. So constantly being informed of also what has been. And I think that is something that sometimes we forget when we talk about, oh, now everyone should have a diagnosis. And in the summer, I've been in so many media discussions with scientific reporters saying, but you're thinking about this in the absolute wrong direction, because all these women that are now getting ADHD diagnosis, are they really the only thing that they have there, like hormonal imbalance or whatever? It's like they're perimenopausal symptoms, and then we try to help them to keep more than one thought in their head at the same time, because you have to look back. Obviously, if someone has led a problematic free life up until the age of 47, then suddenly explores like sleeping problems, executive problems, cognitive difficulties, then you should probably like suspect hormonal factors and perimenopause. But if their life has been like a lineup of like failing at things or masking or compensating and constant like repeating yourself in certain difficulties and areas, then you probably couldn't just settle for the hormonal explanation. You probably will have to realize that this is perhaps a capable woman who have arranged her life living at the absolute maximum of her cognitive capacity, making it like white fists every day. And then when the hormones starts like failing her and her brain starts failing her, the strategies are not in place anymore, and then the symptoms will display for people around him and her.
Yeah, and both can be true. And I think that's what people struggle with. And that's we did talk about this, just to remind people they can go back to listen. We talked about it in our first conversation, which I'll link, about how to sparse out the two. Is it perimenopause? Is it ADHD? Is it both? And the analogy that I've used, I made like a piece of content around it. I just use blocks, and I'm like, as we build and our executive function demands and our responsibilities, and finally there hits a place where like the tower can no longer balance.
That's
and
really good. Yeah, that's a really good metaphor.
And that's when you figure out you have ADHD. And for me, it was motherhood. My block tumbled over. For some women, it's perimenopause. For some women, it's having their third kid.
Yeah.
It's always something that makes your tower fall over.
Yeah.
But it's sparsing out the two. I think
and again, you have to have all these hypotheses. You have to be open to the different hypotheses. So neuroscience doesn't matter how desperately we want it to be, but it's not the exact science yet. So you have to be, again, humble to that there are these hypotheses, and the research and the knowledge that we're standing on right now, that is the best possible knowledge that we have today. And for me, being like a serious and honest scientist is always being prepared to reevaluate your hypothesis, always allowing for what you have thought and communicated, and spend so much time researching. When there is new data and there's new evidence, you have to at least look at it and see, is it possible to, often it's possible to fit these pieces together in a way that doesn't throw over the entire paradigm. But sometimes you may have to be open to do that as well. And that's hard, that's difficult, but I think that's absolutely one of the like core things that we have to never compromise with.
And hopefully the media gets on our side a little bit, because I'm really sick of seeing headlines of like ADHD is being overdiagnosed, and also not helped by some very popular scientist and neuroscientist with very, very popular podcast and millions of followers putting out that ADHD is being overdiagnosed. And it's like you're looking potentially at one section of the population, and you're forgetting about women and girls and minorities and non-gender conforming people.
Yeah, and that again, having to being able to keep so many more thoughts in your head than just one, because it can be over and underdiagnosed at the same time. And I think that is what's happening now in Sweden. In this small country, there are huge local differences in the prevalence of ADHD. Basically, it is tied to how the system is rigged. And that is really scary. And that is also when people are talking about this and not taking responsibility for the downstream effects of what they're saying, and also the ingoing values. But it doesn't really say that much about how ADHD affects society. And then looking at another society saying, okay, so there are so many people asking to, we're overwhelmed by all these people, all these women, basically often, because it becomes offensive first when the girls and the women also are actually requiring some kind of attention. But we're overwhelmed with all these. They think they have ADHD and they think they have everything. And again, back to the tinfoil diagnosis. Yes, perhaps these women have been searching and looking for why they are not making it in this life and functioning the way they should. So wouldn't we rather be interested in why so many percentage of the kids and the adults today cannot get their shit together, cannot get their life work? So maybe it's a combination of us knowing more about ADHD, actually seeing it, diagnosing it correctly, and a combination of a society and a world that is so much more cognitive demanding than it was 30, 40 years ago. Because there's also something with the social media and the constant digital access to everything. Things are going so fast, and that is doing something definitely to our kids and young people today, and to us. I find it much more difficult now, and I think that is partly perimenopause. It is my ADHD, definitely, because it's always been difficult, but it doesn't really help that I'm also constantly distracted by all these things, and also that things has to go so fast all the time. So there's not really time for me to try to apply all these ADHD tools that I am supposed to do, because the world around me doesn't wait for it.
It doesn't wait, and it's so stimulated, and it's so full of instant gratification. And it's so like just constantly sitting there and like calling your name like this siren, just like.
Yeah. And that affects everyone, but it affects ADHD people in a certain way, and borderline ADHD people, like sub-threshold ADHD, will probably tip over to having a full diagnosis an environment, in a society rigged this way, rather than an environment, society, school setting that is rigged in a way that is actually to the ADHD brain.
Yeah. Yeah, I agree. I think there's so many environmental factors, but how
Mhm.
do we slow the world down?
Exactly. That is exactly my argument when people are saying, why do you keep diagnosing people? Why don't you stop? The prevalence is there now. You should stop now because there are enough ADHD people out
We've
there.
reached our cap.
Exactly. We reached it. So stop. And I say, well, I will stop when it's a school and a society that will accept these kids as they are, but it's not. So the only thing I can do to improve their abilities of succeeding in the world, not developing addiction and other psychiatric comorbidities, is to actually give them a diagnosis and the proper treatment for ADHD. So that is what I'm going to do until I see some signs of the school system, the society as a whole, coming together and like creating a neurodiversity certified situation, because it's not. And again, I think what's happening now, what is good, I think, is that even neurotypicals are beginning to like, but this is crazy. You can't let the kids have their phones in school. No, you can't. And for an ADHD kid sitting with their phone in the classroom, there's not going to be very much information intake. Not for a kid
Mm.
without ADHD either, but maybe some. So they're better off. But the important message here is that ADHD adapted pedagogic settings is good for everyone. It is
That's
good for
it.
the ADHD. Yeah, it is like absolutely crucial to the ADHD kid. But it's also better for the neurotypical kids than traditional like schooling, and it's also better for the teachers. So it's clearer and more structured, and it leaves more room and energy to actually do what they're supposed to do. So as teachers, it's like win-win-win situation when you design and rig schools according to what we know from neuroscience is good for ADHD brains or and autistic brains.
But not even just schools. That's like I
Yes,
wish they would
exactly.
be
The
better. But
places.
in
Yeah,
general,
yeah.
all the
Workplaces.
things that we know are like good for us as humans.
Yeah,
Movement, fresh air,
yeah,
nature.
yeah,
Those are good for everyone, but they're like especially good
yeah,
for
yeah,
us. So obviously last year we had ADHD Girls to Women come out in
yeah.
English.
Yes.
You're currently writing a book that will come out in
Yeah.
English. But
Yep.
what about your other books that you've already written? Is your
Yes.
publisher going to
So
be releasing more in
Uh,
English for
yes.
us?
So what's happening now is actually that we are currently translating ADHD at work.
Oh,
So
great.
so that is basically what we were talking about now. So we have to ADHD certify schools, but we also have to ADHD, or we call it neuro inclusion or neuro
Mm.
inclusion at work, increasing the possibilities for participation and for also informing managers, team leaders, HR staff about neurodiversity and what they have to gain from increasing the knowledge to increase participation, inclusion, and to acknowledge and raise awareness about diversity, and down the stream actually improve the efficacy and productivity of the workplace. So there's again so many wins here if you just acknowledge that all brains are different, and the basic knowledge about neurodiversity can be used to apply like structures and knowledge increasing activities in the workplace. So that's I'm so super excited about that. I'm also giving a lot of talks on that topic now, and it seems like you have come further in this department in the English speaking world than in the Scandinavian countries. So
Oh.
I'm really look forward actually to having this book translated and see how it's received. because yeah, it's going to be really, really exciting.
Even as far as maybe some places have come, I still think there's a long way to go.
Yeah.
And I think there's still a lot of things that are quite performative by
Yeah.
companies. And there
Yes.
really needs to be like some substance really going
Yeah.
into like the whole amount. You also have a book not translated yet about adult diagnosis, and you have a book
Yeah.
about parenting.
Yeah. Exactly. So the first book, the first book I wrote was actually about motivational interviewing for parents, and that's only in Swedish.
Mhm.
And then I wrote together with Martina Nelson, who's a psychologist. We wrote Black Belt in Parenting. That was been very well received in schools and for parents, and that's also a little bit of a broader perspective, not only ADHD but all mental disorders in children, and very specifically guidance how you as a parent or a teacher or another adult around these kids with ADHD, autism, language disorders, intellectual disabilities, all these different like and disorders, what you can do to support these kids and these families. And after that, it was ADHD at Work that is not
Mhm.
currently being translated. And then there is Helena's and my upcoming book then about ADHD and hormones. And I'm so super excited about how that is going to be received.
You
We
have a
write that.
deadline, you said. So does that
We
mean
have
you
a
have
deadline,
like a
yes.
suspected
Mhm.
release date?
Yes, so it should be in the autumn 2025 then.
I still think you need in Letter Life, the in the premium membership.
Expert.
You did
It's
the Ask the Expert.
the AMA sessions, right?
Yeah.
Yeah.
Doing a joint panel with you two, I think would
Yeah.
be
Yes.
brilliant.
Yeah. We're trying to be very like responsive to what users are feedbacking us on, requesting. So if there are people listening now and that would like certain things, then it's just an email away and then we'll do it.
I'll add that you have been generous enough to give me a code for 25% off
Yeah.
premium for the listeners. So
Mhm.
that's in the show notes.
Mhm.
And yes, I would like everyone to do the premium version, but even the free version
Mhm.
is like incredible that
Good. I'm so
it's,
happy to hear that. It's
yeah,
always difficult. You would like to be able to do everything for free, but then we couldn't pay the tech backdrop people who actually can make it good. So it's like it has to
yeah.
be this way.
It's such a
Uh,
well-designed app, and it has
mm,
so many features
mm,
between Mind Hub, the community board, the
yeah.
tracking. It prompts me every day because, of course, I'm going to forget. It also prompts me when it's like, hey, have you started your period yet? And I'm like, oh, yeah, I forgot to add that. I thank you once again for your time. I appreciate you just
Thank
opening
you.
your brain and letting us all learn. And yes,
I
thank you.
so appreciate these talks and conversations. They're always, you never know where they're going to end up,
No.
and you just have the best questions and also so relevant. Thank you for sharing and opening up your brain and your life as well. It's amazing, and I know it helps so many people.
Hopefully. We're both trying to, as you said, move the needle just a
Yes,
little
yes,
bit as much as we
yes,
can.
really. So nice to talk to you again.
You as well. I hope you have a fantastic
Yes,
rest of your day.